It's a real pleasure this afternoon to introduce one of our own, Dr. Guidot. Dr. David Guidot is the Director and Jeffrey R. Fine Endowed Professor of Medicine. He has led the Division of Pulmonary, Allergy, Critical Care, and Sleep Medicine for how many years, David? 6 years. He's been at Emory for a number of years prior to that. Before that, he was at the University of Colorado doing his pulmonary fellowship. He's going to be talking about medical decision-making in stressful situations, a personal perspective. And with that, I will turn the podium over to Dr. Guidot.
Well, thank you, Dr. Stevens. In the past, when I've given grand rounds, it's in my role as physician scientist, talking about translational research and the mechanisms by which alcohol or HIV affect the lung. But today we're going to do something very different. First, I need to say that I'm really filling in for someone. Sushma Cribbs, for those of you who know Sushma, and Sushma is one of my favorite people in the world. She was going to be talking today about her clinical research in HIV and lung disease. Tragically, her mother was killed in a car accident, and Sushma was unable to be here today. We will bring Sushma back in the spring at our next pulmonary slot. So I'm filling in, and I'll apologize up front for not being Sushma because she's a much more charismatic speaker. So given the fill-in status, I decided to do something quite different. And being inspired by recent grand rounds in the past month, I decided to expand on a topic that I've spoken about at noon conferences over the years with the medical residents, which is how do we make decisions in stressful situations in medicine? And the subtitle, A Personal Perspective, is important because this is going to be a very personal perspective and a personal history of how I, as a physician, but also focusing primarily in critical care, have thought about how we make decisions and on what basis we make those decisions. So I have no financial conflicts. I have been funded for my research that is unrelated to this topic by a variety of agencies, but have no financial conflicts on the topic. And I want to make it very clear that I'm not a bioethicist, don't pretend to be. But like the vast majority of physicians, close to 100% I gather from my experiences, I strive to be ethical in all aspects of my medical practice. So we'll be talking about some topics that a lot of people wrap up in the concept of medical ethics, but it's really medical decision-making, and it's impossible to extricate any one aspect from another. So the first thing I'm going to do is start with a definition of medicine. Everyone may have their own definition of medicine. This is one I've carried with me for a long time, and it's medicine is decision-making in the face of uncertainty. And to the best of my knowledge, the author of that quote was my father when I went off to medical school. And he was a very interesting guy, very, very smart. But I also want to point out that he is the same person who a few years earlier said when I went off to college, he told me to write when you get work. And the message was clear, get a job while you're in school. So he was a guy who had grown up in the Depression, got drafted at the end of World War II, spent a year in the Philippines looking for holdout Japanese soldiers in the intelligence corps, used the GI Bill to go to college and medical school, and finished all of that at the age of 24. So he was a little bit smarter than me, but he was a bit of a smart aleck as well. So the first case, many of the residents have heard me present, and this is the one case that I've used in the past with the medical residents I'm going to go through. And it's a case from my own personal experiences that I think really bring to light how difficult decision-making can be in certain situations. And this is the case of I don't want to be intubated. So there was a 19-year-old woman with a long history of asthma who presented to the emergency room at the University of Colorado with status asthmaticus. She developed progressive wheezing and dyspnea after a URI the week before. This is a very typical story in someone presenting with status asthmaticus. It's often evolving over a number of days. She'd been using albuterol every 1 to 2 hours for several days without relief. Although alert and conversant, she is in obvious and severe respiratory distress with tachypnea and significant use of accessory muscles. She's treated with supplemental oxygen. She gets repeated beta-agonist NABs and IV salumedrol. Over the next hour, she becomes progressively dyspneic and fatigued. The ER physician advises her that she will likely need to be intubated, but she adamantly refuses this option. Several physicians, including the attending ER staff, speak with her. They advise her that she may die without ventilatory support. She repeatedly declines this option. They are absolutely convinced that she understands the implications. She is admitted to the MICU. Even as she is being transferred, she's rapidly deteriorating with worsening respiratory distress and obvious fatigue. She's barely able to converse at this time. The pulmonary fellow goes down to meet with her because she's been called to admit her to the MICU. And she speaks with her, but she again is told that the patient refuses intubation, even though she was told very clearly that she will most likely die without ventilatory support. The pulmonary fellow calls you at home to tell you about the case, with the essential issue being, I want to let you know that this woman is probably going to die. So, what do you do? Well, I was the attending, and I had been a fellow a few weeks before. So this is my first month as an assistant professor following my fellowship at the University of Colorado, but I'm the attending. I'm the last exit before freeway. So the issue in this case is patient autonomy really the trump card? And although she is 19 years old and may be competent in a strictly legal sense, is she really autonomous? And is she truly competent in this acute setting? And how much do we really know about her? Is she depressed? Has she suffered a recent psychological trauma? A lot of times when I'll present this case, people will say, well, did anyone ask her, maybe there's a reason she doesn't want to be intubated and on and on. And I've thought about that a lot. First of all, I didn't have the option of asking her those questions anymore because now we're at a critical decision-making moment. But I've thought a lot about this over the years, and I thought, especially now that I have children in their 20s, when this happened, my daughter was 4, but having now raised 2 people through teenage years, 19 seemed really old and cool when I was 12. It's very young when you're an adult. But then I thought, is there any answer to any question you could pose to this young woman that would explain and or justify a decision to let a 19-year-old die of asthma in your emergency room? So what did I do? So I instructed the fellow to sedate the patient if necessary and immediately intubate her. The fellow did not want to do this. The nursing staff did not want to do this. There was a lot of conflict because nobody wanted to see this young woman die, but everyone felt absolutely obliged to follow her wishes. So I rushed to the MICU and we intubated the patient emergently. After a few hours of interesting hemodynamic issues, and as an aside, if you take care of people in the ICU, when people come in with status asthmaticus, they're often sick for a number of days. They haven't been eating. They haven't been drinking. They're often very volume depleted, and they're taking very, very strong negative inspiratory breaths to try to breathe, and so their blood pressure will be somewhat artificially in the normal range, but they'll have a very large pulsus paradoxus, which this woman had. The problem is, as soon as you intubate them and put them on positive pressure, they have no blood pressure, and it's very, very rocky. So for several hours, things were very difficult, as they are predictably in this setting, but you can imagine that only intensified the angst among the staff about what we were doing. However, she improved very quickly, and by the next morning, her bronchospasm had resolved. I spoke directly with the patient. She had an endotracheal tube in, but was wide awake. Told her that we were going to remove the tube, but if there were any issues, we would have to put the tube back in. She understood, nodded her agreement. So after extubation, she looked and felt well. I asked her if she remembered the events of the ER and ICU admission. She had a clear recall of all the events. When I asked her why she refused intubation, she said that she had been intubated when she was 13 and that she had had recurrent nightmares from that event. In fact, as with some 19-year-olds or some 39-year-olds, the way she managed her asthma was not take very good care of it when she felt well, but when she got sick would go to an emergency room. A key point about this case is Nobody at our hospital had ever met this young woman. She had never been to the University of Colorado. There were no medical records. There were no family with her, no friends. And this is just how she managed her asthma. She'd go to the emergency room and she didn't feel well. And she had multiple times in the past been told, you're very sick, we may need to put you on a ventilator. She'd always refused, and she'd always gotten through without needing to be ventilated. So she thought this was just, again, people saying, you might have to have this. And she had always thought she would pull through, and she thought she would pull through this time. Now, this time she said there was no problem. And a key point, again, if you practice critical care medicine, when someone comes in with status asthmaticus, putting the tube in does nothing to treat the asthma. All it does is give you control the upper airway, which is not where asthma is causing the problem. So the air hunger and the fear and the anxiety is incredible, and it gets worse when you put a tube in. Whereas morphine, which is a great drug to take away air hunger and anxiety, I use quite liberally in these cases, and she said that was fine. She didn't have nightmares the night before. Now, the patient's mother arrived at the hospital and was surprised to hear that her daughter refused to be intubated. She was grateful for the outcome. Can you imagine sitting down in a room and explaining to this mother that her 19-year-old died a few hours earlier in these circumstances? I can't imagine having that conversation. Now, the pulmonary fellow and the ICU staff, who originally expressed concern that I was committing assault, said that I could say, "I told you so." Uncharacteristically of me, I said, "No, I won't do that." I told them I would make the same decision again in similar circumstances, even if this patient had screamed at me and called the police after she was extubated, which I didn't think she would, and she did not. So she got discharged the following day, and I wrote an excuse for her to go back to work at McDonald's, where she worked at as a cashier. The second case to present is, I titled it, "I Felt Like I Was in a Eugene O'Neill Play." So this was a number of years later. I'm now on the faculty at Emory. I'm attending in the medical ICU at the VA. And a man with a history of heavy alcohol abuse and smoking comes to the emergency room with massive hemoptysis. He's coughing up enormous amounts of blood, but intermittently. A chest x-ray showed diffuse pulmonary infiltrates, and he's admitted to the MICU. He's alert and oriented, but is shouting at the medical team who tries to evaluate him and repeatedly says, "Just leave me alone. I don't want anyone to touch me." Now, his nurse interprets her role as being the patient's advocate and stands between the patient and the medical resident, pulmonary and fellow, and insists that they respect, obey the patient's wishes and leave him alone. It's a very stressful situation. So you're called urgently to the MICU by a very distressed fellow and rush in to see this tableau. As I said, I walk in and it was like I was in a Eugene O'Neill play. There's the patient is backstage. There's the nurse standing in front of her. She's a very imposing person. She genuinely believes that her role is to help advocate for the patient's wishes. You have the medical resident, the fellow who can't get to the bedside. They're really stressed, and you have to figure out what to do. The patient's clearly very agitated, repeatedly shouts that he just wants to be left alone and doesn't want to see any doctors. So what would you do? Again, this is a very personal perspective and journey, and I don't imply that this is the gold standard, but these are the situations you wind up in sometimes. So I asked the nurse to leave the room. It just was so charged at that moment. So I asked her to please leave the room, and I wanted to speak with the patient alone. And I explained to him that he had a life-threatening problem and that I wanted to do my best to identify the cause of his bleeding and whether or not there was any treatment possible. So what I told him is, this is what I do for a living, and I'm very good at it. That may have been embellishing it, but I wanted to emphasize this guy, this is why I'm here. I'm here to help you. Let me take care of you. So he agreed. So we sedated him, we intubated him, and we evaluated him. We did a bronchoscopy, we did a CT scan. He had extensive bronchiectasis, which was the likely source of his bleeding. We didn't find any cancer. I've had a number of cases in my career where someone comes with massive hemoptysis, you identify an endobronchial tumor that you can treat definitively, but you have to know where the bleeding's coming from. But he turned out to just have bronchiectasis, which can cause life-threatening hemoptysis. He actually did very well, and he was discharged a few days later. I didn't see him again. I don't know how his overall course was, but at least in that acute setting, we did what we thought was the right thing medically. So cases like this and other cases, and me thinking about this as I go through medical school and residency, made me ask, on what basis do we make medical decisions? Seems like a very simple question to ask ourselves. And my interpretation of this, going through since starting medical school in 1980, is that this is pretty much what people practice or what they think. And this is not meant to take anyone on or offend anyone. I just think a lot of times we think this is how medical decisions are made, is that there's a lot of things in the upper part of the pyramid here, medical evidence, costs, available resources, a variety of things, but that fundamentally there's this bedrock foundation of patient autonomy that ultimately is the gold standard and is the basis for medical decision making. So, Webster defines autonomy as this. I won't read it. I think most of us have a sense of what autonomy means. But this idea of being in control, being in charge of your own fate and your own decision making, it's a very important principle. I am not saying that we need to be in a paternalistic system, a maternalistic system where we just decide and tell people what we're going to do. So autonomy is a very important principle and one I embrace very strongly. But the problem is it really the fundamental basis for medical decision making? It is in certain contexts, but not in every context. And I would argue that the first two cases are examples where autonomy or the perception of patient autonomy changed people's medical decisions in ways that I think we have to be concerned about. That first case I described afterwards, so I'm a brand new attending physician. I'm at the University of Colorado, which even then had over 100 faculty, and I presented the case, and half of the attending physicians, even knowing the outcome, said they would not have done what I did. Half said they would. So it led me to realize that these are very challenging issues, and we don't often discuss them. And a lot of times medical students, residents, and fellows are left filling in the vacuum because they're unsure how to make these decisions. And clearly, they're always going to be hard to make. But the question kept coming up to me, is autonomy really the fundamental basis? And the problem is, while it's important, there's a lot of exceptions to the rule. So if this is a fundamental, bedrock, inviolable concept or rule for decision making, what do you do when you have so many exceptions to that rule? So we have protection of minors. If you have a family who are, because of religious principles, decide that they don't want a certain medical treatment for their child, Oliver Wendell Holmes, when he was Supreme Court Chief Justice 100 years ago, said, you can make yourself a martyr to your religion, but you cannot make your child a martyr to your religion. So you can have great respect for people's personal beliefs and religious beliefs, but we as a society anyway have decided you have a moral and a legal obligation to do the right thing medically for a child, even if it's against the wishes of a parent who may love their child very, very much and be a wonderful parent. And we have protection of the patient or others from harm. Think about that first case. How many people who went through residency had someone come in with an overdose in the emergency room and had the patient flailing and fighting with them and still held them down and put it in an NG tube and did things to try to reverse the overdose? I mean, that's someone who wanted to commit suicide, is in the emergency room, doesn't want you to do what you're doing to them, but we do that because we're trying to protect them from harm or others from harm. We have social rationing. You can't walk into any place, including Emory, and say, I want a lung transplant, as an example. You may want one, but we can't give it to everyone in our society, even if they meet physiological criteria for it. It's a very complicated issue. We all struggle with it. No one wants to be the person making those decisions, but we have to recognize that we often do rationing of medical resources. And then there's futile care, which is a very difficult definition to come to and often causes the greatest amount of angst in the intensive care unit, for example. How do you define futile care? And it's a challenge, and I'm not going to give you that definition, but I think there's many cases where we know when it's futile, and there are statements from medical societies, and I'll share at least one with you later about that. So when there are so many exceptions to a rule, it's not a very good rule. It's a very good guideline. It's a very important principle. Please understand, patient autonomy is very, very important. But decision-making can't rest only on that. You can't walk into a room and say, Your dad has pneumonia. We're thinking, there's evidence that a quinolone would work, but maybe a beta-lactam. Which one would you like? We can't do that. We have to provide our guidance and our judgment. So do we have a better fundamental basis or rule for medical decision making? Well, I would argue that we do, and I think we all know it intrinsically, but it's cases like the first one in particular that cause so much anxiety among physicians because we intrinsically understand the primary rule but feel bound by these adherence to autonomy. So going back to the Hippocratic Oath, I never took Latin. I know I'm old, but I'm young enough that they didn't have Latin requirements in medical school, but primum non nocere, I'm told, is how to say it. That's probably not even close. But beneficence and non maleficence. So first do no harm, do good and not bad. That's pretty straightforward. I translated that into a more modern context, Do the Right Thing, one of the really great movies of the latter part of the 20th century. Lost out to the Academy Award to Driving Miss Daisy, a charming little movie. But this, if you've not seen it, is one of the really brilliant movies. The key thing is do the right thing. You know what the right thing is, or you try to, and that's the fundamental basis in my mind, and I'll expand on that. It doesn't mean that that is at odds with patient autonomy or family autonomy. What patient of yours, if you told them, I want to do the right thing for you, would say, give me a different doctor. If that's your motivation, I don't trust your judgment. So let me back up now. So I've shown you a couple of cases that, and believe me, the key thing about those first couple of cases is I was scared, and it was very stressful as well. And so what I'm trying to share is a little bit of my impressions of what are the basic principles and how do we make good decisions in stressful situations just the same way we can make decisions when there's plenty of time to contemplate. So let me share with you a little bit about my personal journey through this situation. So this is how I felt when I was an intern. I felt like I was about 10 years old. I was 24 when I graduated from medical school. When I was on call, the nurses would put boy on call because I was so young. But I probably look like this to my patients. It's a very frightening thing to suddenly be an intern and be taking care of really critically ill patients. And that's when I first encountered this line, which is one of my fellow interns in 1984. In 1984, at least where I trained, this was, and this kind of cynical comment is really, it's kind of funny in some way when you're the intern on call, but there's nothing funny about it. It's very cynical to think this is how we're managing the last moments of a lot of people's lives whose death we can predict and should be taken care of in a very different way. So one of my fellow interns said, people here don't die, they code. And that's because we probably did 4 to 6 codes a day. And the vast majority of them were in patients who their death was predictable, inevitable, and the code was a perfunctory last effort we were required by the administration, by our teachers and everyone to perform. So how do we know when putting a patient through all of this is the right thing to do? And when we know it's the wrong thing to do, what do we do? And which brings me to the next important quote for me. It was easy to say that we did everything we could when I trained because there was so little we could really do. When I was a medical student in 1982, one of the first patients I ever had the privilege of being involved in her care was my first rotation, first day. I'm on medicine, brand new third-year medical student. A woman got admitted to the University of Michigan Hospital with bronchogenic carcinoma, significant hemoptysis. The cancer had been unresponsive to chemotherapy and radiation therapy. She was not surgically resectable. She was very scared. I was talking to her for a long time about what she wanted and what she was afraid of. She wasn't afraid of dying. She wanted to live, but she was more afraid of suffering. And so I'm talking to the medical resident, and he said, yeah, there's really nothing we can do medically. Can you call her doctor, the University of Michigan faculty member who was involved in her primary care for her cancer, and tell him that? So I called this person, and I was very naive. I had no idea how to have this conversation, but I introduced myself as the medical student, and I said, this is the situation with Miss So-and-so, and so we need to just make sure she's comfortable. No one knew the terms comfort care, palliative care. There was no DNR that I recall. And he started yelling at me. How dare I abandon the patient and not do everything? We should do everything that was absolutely possible. And it was a very upsetting experience, obviously. We had to call thoracic surgery. They came by and said, we can't do anything. The woman wound up in the intensive care unit and had a very, very unpleasant end. Now, the physician I called didn't wake up that day saying, I'm going to be a bad doctor. He was a very hardworking, very smart person, thought he was doing the right thing. And then over the years, I've thought about that. So if this is 1982, I'm 55. I trained in the 80s. That's 30 years ago. This physician probably trained in the 50s and 60s. So this quote, it was easy to say that we did everything we could when I trained because there was so little we could really do. The challenge now is not just to know what you can do in the 1980s, and I would say still in 2015, but also what you should do. And so for many decades, physicians didn't worry about what should they do necessarily. I don't mean to imply they didn't have a conscience, but there was so little you could do for some of these things that it never really came up that, oh, we shouldn't do these things. And again, this was my father, who had trained in the 1950s, who said, look, Dave, because I said, I'm really having a hard time with this. I have all these patients in the intensive care unit, I have all these issues going on, and I don't feel like I'm being a very good doctor. And he said, well, when I trained in the 1950s, if someone stopped breathing, they died. If their heart stopped, they died. If they had renal failure, they died. Now you have all these technologies, so the key is not to know what you can do, but what you should do. So this is my father in the middle. He started the first pulmonary function lab in the city of Detroit. He ran a teaching program at a teaching hospital in the city. And if you do the math here, he died at age 58, halfway through my second year of residency, when I was still having all these cognitive and ethical dilemmas I was facing, as we all do as we train to be physicians. So what was going on at that time? Well, this is a paper that was published out of the University of California, San Francisco in the late 90s, and it was a very interesting survey. It was done in one ICU at UCSF. John Luce, who writes a lot about medical ethics and critical care, looked at a one-year period in one of the ICUs at this large teaching university. And in 1987 to 1988, which was the same year I was a chief resident in Minnesota, I'd already finished my residency, a recommendation to withhold or withdraw life support preceded 114 of 224 deaths, 51%. And as a result, CPR was attempted in 49% of patients at the time of their death. Just 5 years later, I would argue that there were no great advances one way or another in technology, but just 5 years later, a recommendation to withhold or withdraw life support preceded 179 of 200 deaths. That's 90%. That's a sea change in just 5 years. Now, that's one institution, but I think a lot of that was going on in a lot of institutions. So what was happening at that time? Well, you had professional societies like the American Thoracic Society, other societies like the Society of Critical Care Medicine that were starting to address these topics. They were having expert panels, they were discussing it, and they were putting out opinion pieces. And this one was a very profound one for me because it came out when I was a fellow at the University of Colorado, and it was entitled Withholding and Withdrawing Life-Sustaining Therapy. And what was interesting is section 1 was respect for patient autonomy is the primary basis for withholding and withdrawing life-sustaining therapy. People forget that the living will movement did not originate because people were afraid physicians would do too little, is they didn't want physicians doing too much at the end of life when the quality of life was not there. Living wills were never meant to protect people from us being apathetic. They were to protect them from us doing everything and treating their body as if they had a pulse, that was the goal. So respect for autonomy is critical. The question is, how do you put that into your decision making? How do you talk to people about that? The next section in that was when a patient lacks decision-making capacity, a surrogate decision maker should be identified to help. The key word in this statement, and I've read this statement 1,000 times, is to help make decisions on the patient's behalf regarding life-sustaining therapy. So often we find the third cousin and tag them and say, you're it. And say, now what do you want us to do? That's abdicating our role in that context. But yet we want to obviously engage family members and loved ones and talk about how do we make these decisions together. A life-sustaining medical intervention can be limited without the consent of patient or surrogate when the intervention is judged to be futile. The definition of futile is difficult, but I would argue that if you have someone at a major medical center and every single person involved in their care says there is no meaningful chance of recovery and all we are doing is prolonging suffering, that's futile. But it's amazing how often, even in the modern era, there are people that struggle with that. And I understand why they struggle with it. But I don't know if many physicians still understand that you can limit that. I mean, you never hear a surgeon say, I knew an operation would help, but I had to do it because the patient's family insisted I do it. But how often do we provide intensive care and interventional care, even though we think or know it's not the right thing to do, but we feel like, oh, someone says they want it done, their autonomy trumps everything else. And that's where we get into trouble. And anyone who's spent more than 5 minutes in an ICU or another setting understands that those situations still come up every single day. And they're challenging. They're very hard. The other thing is healthcare institutions have responsibility to promote ethically sound decision-making regarding life-sustaining therapy. Couldn't agree more. But how do we do that? We have ethics teams, which sometimes I think we invest too much in because we expect too much of them to come in and make decisions for us. We obviously need their guidance and their input, but institutions still struggle with this. I would hope that this grand rounds might be part of that discussion, although I'm not pretentious enough, surprisingly, to believe that I'm going to make a huge impact on how we as an institution address these issues, but it's one part of that. So the issue is, how do we talk to people? So here's how I was taught to ask people about what their medical care when I was a medical student. Before I could do that, sorry, I wanted to quote Paul Wolpe, who was here 2 weeks ago, when he said, I don't go to my physician for non-directive information. I go to him because I want him to tell me how to manage my problem. And I talked to Paul and let him know that I would be quoting him, and I ran the quote by him and said, are you okay with this wording? He said, absolutely. Because he had a really wonderful grand rounds a few weeks ago about ethical decision-making. So this was what I was taught. And I think you hear it less often now, but you still see it quite a bit. If I was taught to go to a patient or the family and say, if your breathing stops or your heart stops, do you want us to put you on a breathing machine or try to restart your heart? So no matter how smart you are, if you're not a physician, or maybe even if you are, what is the translation of that? Do you want us to save your life? If you're drowning, would you like me to throw you a life jacket? I mean, what answer can they give? It's so out of context. I mean, if I'm lying in bed with abdominal pain and a surgeon comes in and says, I think it's appendicitis, do you want me to operate or not? I'd say, well, first go find me a doctor. Find me a surgeon. I'm sorry. I mean, no offense, but I mean, I'm not picking on the surgeons. We do it all the time. It's like, I want someone to give me their judgment, give me their recommendations. I can say no, but most of the time I'm going to say yes because I have a bond or I have a trust with this person, whether I've known them for a minute or an hour or a year or whatever. If they come in and they do their job well and explain what's going on and make the recommendations, I need that, right? But we abdicate that responsibility. What if it's the wrong thing to do? I mean, why are you asking them to decide that? Do you ask them to decide whether or not you're going to use Levophed or dopamine or an aminoglycoside or not? No. So why do you go to somebody like that? So where this really hit home, and if I can share another personal vignette. So I showed you the picture earlier of my father. When I was a second-year resident, he was diagnosed at Christmas time with a glioblastoma. He was dead 8 weeks later, 58 years old. So I'm taking multiple nights of call in a row in Minnesota so that I can get a day and fly to Detroit. It was just a weird time. So I'm up for 60 hours. I catch a plane. I go home. I'm trying to visit back and forth. It didn't go on for very long. And I was on call in St. Paul at the county hospital, and I get a call from my sister that Dad's going to die. So I race I'm on call. I get somebody to cover my call. I race to the airport. I get there, and when I get to the hospital, now I've been traveling for 5-6 hours, but it's not far from Minneapolis to Detroit. But you got to get to the airport. You got a flight. I don't know. So I get there. My mother comes up to me, and my dad's in neurogenic pulmonary edema. He's unresponsive. My mother comes up to me and says, "The doctors asked me if we should code your father, and I didn't know what to say. I've been waiting for you to get here to tell me what to do." And that really hit home for me. Now, this is 1986. Again, these are doctors who really were trying their best, but they felt obliged from their training to go and ask this woman who's losing the love of her life, what do you want us to do? So, of course, I said, no, let's not do that. But why was she in that position? Why was she being asked? These were not bad doctors. These are very good people. Why did they feel that that's how you practice medicine? And so that event and my own medical training really is what got me on this journey of trying to figure out, why are we making decisions the way we do? How do we talk to people? The other thing is, somewhere along the line, CPR and intubation became different. They became this, not to be touched, sacred, separate box that we can't decide, we can't advise very strongly, and we have to, whatever the patient or the family says they want around these two items, we have to do. And if you think I'm wrong, you just spend much time in intensive care unit and see how often this comes up. How did they become so different without any frame of reference? I don't know, quite honestly. I think it's because CPR only was developed in the 1960s. Routine intubation, mechanical ventilation outside of an OR only became available in the 1960s. So by the time you had really well-developed ICUs in the 80s, when a lot of us trained, or 90s, people hadn't thought through these issues. So what our patients really want and deserve, I think, is our best medical recommendations based on our experience and knowledge. Now, a lot of the audience knows this, and really most of this I'm pitching at our young medical students and residents. There's many physicians in the audience as I look around, and certainly at the distant sites, that are probably so much better at this than I am and way ahead of me. So please understand that I'm not trying to pretend that I'm at the top of some mountain here. But our patients really need our recommendations. You do it every day. You sit in your clinic and you say, you have high blood pressure, here's what we need to do, or you have diabetes, I recommend this treatment or not. We do that all the time. That's what patients want. You can't give them the medical literature and ask them to sift through and decide what to treat anything. And so, but we really are so uncomfortable with that final, what we think of as a final decision, CPR, intubation, these things at the end, that we sort of step back and say, what do you want us to do? We think we're doing the right thing, but we're not. So the key is do the right thing. Now, it's hard enough to know what the right thing is, but oftentimes in medicine, we feel that this is the right thing to do when we make that recommendation. And we need to do that in these tough times, too. So what I've done over the years is change how I talk to families and patients in the ICU. I'll say things like, you're very ill, we'll do everything we can to take care of your problems. There are some things we can potentially reverse, but some things we cannot cure. Our primary goal is your comfort. And I'll say there are some medical treatments that will not help you and should not even be tried. And I don't go through a list. I don't say dialysis no, pressors no, this no. I say, look, there's some things that just aren't going to make you, they can't prolong your life. They can only prolong your suffering. And we're going to do everything we can to take care of you and give as much quality time and all that. I've never had a patient since. I mean, for a decade, I would say, we shouldn't do this, we shouldn't do that, we shouldn't intubate you, we shouldn't. Lots of conflict. Since I've started to change how I talk to patients, I've never had a family tell me when I say, look, I'm just trying to be the best doctor I can be for your husband. We're going to do everything we can to give as much time at home as possible. I know he loves playing dominoes with his buddies, or he wants to see his son graduate from college or whatever. We're going to do that if we can. But the most important thing is to know that we're just going to take care of him, respect who he is, and relieve his suffering if we get to that point. I've never had a family say, no, I don't like that approach, doctor. Whereas I had many years where people said, no, I don't like you telling me I shouldn't have this or I shouldn't have that. So the issue is how it gets presented. So what I often say to the residents is, if you race into a room to respond to a code and you and everyone else involved secretly hope that your efforts are unsuccessful, then what are you doing? What are we asking you to do? That is a terrible place to put a young doctor or a young medical student in, to put them in a situation where they have to do something and hope that they're unsuccessful because they know in their core that's the wrong thing to do. We need to resolve this conflict, in my mind. We're better at it than when I was in my training, but we're not done. So let me give you a couple other quick vignettes, and then we'll finish up. So last year, I was making rounds in the VA ICU, and a patient came in. It was the very unusual veteran patient who in his 60s was on no medications. Think about that. Someone comes to primary care, makes all his visits, doesn't smoke, doesn't drink, very healthy, is on 0 medications. But he comes in with his third massive GI bleed. Baseline hemoglobin was 14 or 15. I come in the morning to make rounds. The residents tell me this guy got admitted last night, massive GI bleed, hemoglobin 6. He's gotten 10 units of blood. The bleeding scan showed he's bleeding from the right hemicolon. I said, where are the surgeons? And they said, the patient doesn't want to have an operation. And I said, I don't want to have an operation. I looked at the resident and said, do you want one? Do you ever wake up in the morning and say, I hope I have an appendectomy today, let alone a hemicolectomy? I said, nobody wants to have an operation. That's not an answer. I don't know. For the residents who were there, I'm sorry if I came off too strong because I didn't mean to let my passions imply that I was yelling at you because they worked very hard and I love being here. It turned out this was his third admission. Each time it had been localized that he had bleeding in the right hemicolon with diverticuli. And each time he would get transfused, and people had this almost like an urban legend propagating forward. Well, he doesn't want an operation. I said, look, let's go in and talk to him. So I go and I introduced myself. We're talking for a while. I said, this is a bad problem. Aren't you getting tired of all this bleeding? He said, yeah. I said, I think you have to have surgery for this. And I said, because one of these bleeds is going to kill you. I mean, we can't act like every time you bleed 8 units or 10 units of blood that it's a trivial thing to rescue you from this. One of these events is going to be fatal, and you don't have a fatal disease. And he said, okay. I said, I think you need part of your colon. He said, okay. And so we consulted surgery, and the surgery resident came in, and before she had seen the patient said, I'll see your patient, but he doesn't want to have an operation. I went through again. I said, well, nobody wants to have an operation, but sometimes you need an operation, So the one guy wound up going and having his hemicolectomy the next morning. And so part of it is we have to be very careful how we interpret cues. And when someone says, I don't want something, like this woman at the beginning, the first case I told you, sometimes people are just afraid or don't understand the context. So we have to be very careful not to interpret autonomy, even if they're of age and are competent. Like I've often said, now this guy was fine, at least at the moment he wasn't dying in front of me. But like that young woman, I often ask people, if she had $1 million trust fund and I had her sign it over to me in the emergency room, what judge would give me the money? So if she can't make good decisions about money, she can't make good decisions about her life. People are scared. And they need us to do more than just ask, what do you want me to do? So I'll finish with this case. This is the case that I called Only Jesus Can Call My Son. So this was a very pivotal case for me that happened about 10 years ago. I'm making rounds in the ICU at the VA. It's a couple days before Christmas. And we get a call that a patient is transferring down to the VA MICU. And everybody groaned. The residents, the fellow, the nurses, everyone, oh, God. And I said, what? And they said, Dr. Guidot, don't you know this case? This guy has been in the hospital for a year. He's been in and out of the ICU multiple times. It's a really frustrating case. He is very, very advanced HIV with profound dementia, renal, on and on. Very, very advanced case. He's been in and out of the ICU multiple times. And no matter what you talk about with the mom, all she ever says is, only Jesus can call my son. Only Jesus can call my son. I'm not saying that to be disrespectful. This was just how the events unfolded. So he gets transferred to the ICU. I go in and see him. There's this person who weighs about 80 pounds, terrible contractures, has a sacral decubitus that you can look at through the back and see through the front, basically, moaning in agony, uncommunicative. I was heartbroken seeing this. And so I take a deep breath, and I ask the nurses to put the family into a room where I can go in and talk to them. And I'm readying myself, trying to think, this is going to be tough. So I walk in the room, and there's this impeccably dressed, incredibly polite African-American woman in her mid-60s and her 2 other adult sons. She's very polite. We introduce ourselves. And I sat down to have a conversation I've had 1,000 times, maybe 10,000 times before that, and decided I got to do this differently. I haven't been doing it correctly. I don't know what clicked. So I sat down with her, I looked at her and said, tell me about your son. And she looked at me kind of funny, and I said, what kind of kid was he? Did he make you Mother's Day cards, on and on? And she started to tell me about this love of her life, this youngest child of hers who was a delightful boy, well-behaved, wonderful personality. And she just went on and on about it. And then she looked at me and she said, I know what you're doing. And I said, what? She said, you can never love my son the way I love my son. And I said, you're absolutely right. How could I? How could I possibly compete with a mother's love for your son? But I was a son, I told her. And I watched both of my parents die. And I have a son. And if he were lying in that bed, like your son is, my heart would be breaking every minute. I just don't know what I would do. And so we chatted for a little while, and then the line came. She looked at me and she said, I understand, doctor, but you need to understand that for me, only Jesus can call my son. Said calmly, said lovingly, and said with conviction. This wasn't an irrational statement. It was a very loving statement by a woman who felt very deeply that that was how things were. So I looked at her and I said, you're right. You're right. Only Jesus can call your son. But it's not our role to block the call. And he is being called. So I would say I would recommend that we let him take the call. And she said, I understand. So we put him on a morphine drip. He died a few hours later. And the issue was many, many people had talked to her before then and thought that they were being very, should we do this? If your son's heart stops, should we do that? What she interpreted was, should we save your son's life or not? The other thing is she just needed someone, like I would need someone, if it were my son or my daughter or my wife, to talk to me about the person and what we should be doing. So I had spent 10 or 12 years trying to win a debate with families like this. This isn't going to work, that's not going to work, we're going to do everything we can, but we shouldn't do this. And I thought I was doing everything, even though I was evolving and trying to be better at it, I realized I still missed the fundamental issue there. So all my other papers are really boring, like copper, zinc, superoxide dismutase improves response to hyperoxia and yeast and things like that. So I wrote this up. It'll be coming out in press in a month or two in the American Journal of Medical Sciences, and called it Only Jesus Can Call My Son. I'll give you a few quick excerpts. So what I wrote in that is I grew up in a very, very Catholic family, going to church every day and things like that. And my father was at a Catholic teaching hospital and very, very deep convictions, but never wore them on his sleeve, never preached anything to anyone about it. So I wrote, I have to admit that at this stage of my life, I do not have the same faith in a divine force or an afterlife as my father and this woman in my vignette shared. However, I have deep respect for those whose faith shapes their lives in loving and compassionate ways, and this interaction taught me a profound lesson. Even though I was constantly trying to improve my ability to conduct these family meetings, I am much better since that fateful day. However, even if I do this for another 30 years, and I'm 55 years old, so the odds are against me, but I'm going to try. I hope I'll continue to get better each time. And I wrote that whether we believe that our lives end in this world or continue on in some other spiritual fashion after we die has been the great unanswered question that humanity has faced since we became human. So I don't know if Jesus or any other deity calls us. I personally don't, and I don't mean to imply that my beliefs are universally held, because it's a complex. I have a complex relationship with God, let's put it that way. But I do know that as physicians, we are called by our patients and their families to care about them, and that's to care for their illness. And so I learned a lot. This woman taught me so much more in that interaction than in most other interactions I've ever had in medicine. So it got me to thinking about this. For me, this is my own concept, this yin and yang between the visceral brain and the digital brain. As we train young medical students and residents, as we go forward, we're not going to end mortality. We're still going to have very challenging medical issues. And really, I spent a lot of years trying to fill up my visceral brain with medical information and content. So I was, bring it on, medical jeopardy, morning report, I reveled in it. But now I rely far more on the external digital brain. I carry, databases and things. I ask the residents, most of the drugs we use, I can't remember the pharmacology because the drug came out 4 days ago. So the digital brain can hold a lot of information. So as we train people, I really believe that board exams, ABIM exams, that one, you got to figure out the patient has Q fever if you're lucky. Then you got to know what the treatment is. That's not how we should be testing people. And that's certainly not how we should be training people. Yes, you have to be smart, but that information is retrievable. What I'm trying to do now is fill my visceral brain with wisdom. And it turns out that's a lot harder, especially for me. But it's a lot more fulfilling. So Jimmy Stewart, if anyone has seen Harvey, it's a great movie. Near the end, he says, he's quoting his mother. He says, "My mother told me, in this world, Elwood, you must be oh so smart or oh so pleasant." Well, for years I was smart. I recommend pleasant. So for many years when I was discussing these critical decision-making with families and patients of mine, I tried to be smart. And you want your doctor to be smart. But I needed to bring in something else. And so I'm embarrassed now. I actually am embarrassed to think how often I thought that patients and families in the intensive care unit were unreasonable or difficult. We hear it all the time. The family's unreasonable. The family's difficult. There's an occasional unreasonable family or patient. And there were a lot of them when I was the first 10 years. It's amazing. Like the Mark Twain line when I was 11, my father was so ignorant I couldn't stand to be around him. When he was 21, it's amazing how much he'd learned. So I'm still confronted with interactions that are problematic. But ever since that day in the ICU with that woman and her son, I found that patients and families are in fact rarely unreasonable or difficult if I begin our initial meeting with, "Tell me about your loved one." So I'm still looking for the moral high ground. I am not standing on it. This presentation today was not to imply that I'm bringing wisdom to the masses. I just wanted to share with you my own personal journey, and I'm still looking for the right exit to get to the moral high ground. And I'm often reminded of the line, "Those who can't do, teach, and those who can't teach Jim." And that's Woody Allen. And so I don't know if I even had any moral authority to stand up here and talk to you, but I did want to share that personal experience with you. And I do want to say this presentation is dedicated to my father, to my mentors, to our trainees, but most importantly to the patients and families for whom I've been privileged to provide care over the past 30 plus years, however imperfectly. And I'll stop there. Thank you. I don't know if there can be any questions.
Thank you, David, for that very personal story and journey. One question I have, I was intrigued by the presentation at the University of Colorado to a group of physicians, and 50% would not have done what you did in that first case. Can you comment on that, and do you think this audience would have the same reaction?
I don't know. It caught me off guard. I guess it didn't break down even among age, although some of the older physicians tended to be in the "I wouldn't have done that." And I think for me, it crystallized this idea that we really were struggling with, if the patient says they want it or doesn't want it, we have no role there. And I asked a number of people, and they said, "Look, I didn't want to see this young woman die, but you have to do what she says." And I thought of all the times we don't do that. We talk people into what they need because that's our role sometimes. So I don't have an answer to what you're saying. It caught me. I thought it would be maybe 10% would say I shouldn't have done it. The fact that it was 50-50 was very surprising to me. But I keep thinking, I didn't ask them at the time because I was a brand new attending, and these are very important people to me at the time. I didn't think I could take them on, but I thought, how would you have the conversation with that woman's mother? How do you explain that you let a 19-year-old die of a completely reversible problem because the 19-year-old was scared. Carlos.
So, David, that was great. I think that, growing up in the early years of the HIV epidemic when we really had nothing much to do for patients other than providing care, I think I learned palliative care before it was actually called palliative care. But I think a big mistake is that we frequently tell people there's nothing else to do when in fact there's a lot to do. And providing care and comfort is actually care. But this whole idea that we have nothing else to do, I think really scares everybody when in fact there's plenty more to do. And I think it also, it's how you frame that conversation.
Right. Yeah, I agree. I think the first cases that I told you about where I intervened versus the case of the young man who I needed to talk to his mother, they're not distinct. They're two sides of the same coin. It's, how do you make decisions? How do you make a care plan? I agree with you. In the ICU, I try to always formulate a care plan, not here's a list of what we're not going to do. Patients need a care plan. They don't need, do not enter this, there's special toys in that room you can't have. But you're right. I appreciate the comment. I don't have anything else to offer. I'm sorry. To that. Doug,
David, I compliment you. This was quite a wonderful discussion, and I think it's something we need to address. A couple of things, words that you use that I would emphasize, and one you didn't use, and that's defeat. I think most of us came through medicine. Death was a defeat for us as a physician, and I think we've got to move away from that. Many times your role is not to prevent death, but to make the transition more peaceful. I think another thing the term you did use, which I think is important, is certainty. And I think many times in America today and maybe worldwide, as we look at what we can do in medicine, we get infatuated with absolute certainty, and sometimes uncertainty is where we are, and we need to leave it there. It's just not important to do another test to be absolutely certain what somebody has if they're on death's doorstep. Right. I would recommend to the group a book, and that is Atul Gawande's Being Mortal. I think is a wonderful look at these kind of decisions. But again, I compliment you on your.
Yeah, thank you. I finished that book this summer as well.
I was just wondering, this is another way of looking at some of these issues. If you're taking care of a patient and you know their life could be saved, but they don't have the resources to pay for it, do you think one of your obligations should be to climb the ladder at whatever institution you're at and get somebody high enough up to give you permission to do it, even though they will have to pay for it from the institution standpoint?
Yeah, that's a good point, Neil. It doesn't come up as much. There are treatments that are very expensive that we generally think about in chronic illnesses, in our world, pulmonary hypertension, interstitial lung disease, where we say, well, this drug might have this benefit, but it costs $100,000. And that's a struggle we have. I don't know that I would demand that Emory fork over $100,000 for a drug that has maybe minimal effect there. But in a more acute setting, maybe it's because I've been at the VA much of my career, I've never had to think about what it's costing the patient once they're already in the system. But you raise a very provocative point. I know it does come up. You have somebody who would benefit from a transplant and doesn't have insurance. And Emory can only, Emory, we can only do so many transplants gratis because it's millions of dollars of investment. I haven't had to make that decision personally, but I know our institution has and has stepped up, but they can't do it every time, and it's a really big challenge.
Well, David, thank you again very much, and for everyone, have a great Thanksgiving. Thanks a lot.